Welcome to this teaching session on sedation on the intensive care unit. What we're going to do is discuss why we sedate patients on the intensive care unit, and then we'll discuss the agents that we would use to sedate them and the various advantages and disadvantages of each one, and then we'll move on to paralysis of those patients as well, and we're going to add paralysis into our mix of maintaining the patient on the unit. So the first question we really want to ask ourselves is, why do we sedate patients on the unit? The most common reason really is to achieve ventilator compliance. Quite clearly, a huge number of patients come to intensive care either because they have airway failure or ventilatory failure, and they're going to get a tube down their throat and then they're going to go onto a ventilator. To achieve them staying on the ventilator comfortably, we therefore need to maintain a background of sedation. So that is probably the most common reason for that, ventilator compliance. The second most common reason probably is what we call treatment compliance. There are a group of patients who will require some aspects of intensive care who are really not able or not willing to comply with treatment. This may be a head injury patient, it may be an intracranial bleed patient, it may be a septic patient, something where the patient's neurospectrum is disordered, and such in order to gain control of that patient and in order to actually achieve our endpoints of clinical intervention on the unit, we need to sedate them. Clearly those patients, it is very dangerous to sedate patients without a secure airway, so often these patients progress through rapid sequence intubation, maintenance of the airway, followed by sedation on the intensive care unit. And those are really the two main groups, and that's really why we will see these patients on the unit. But then the question comes, what do we use? So we've done the why, what are the agents that we could use for this? If we think in order of commonality, the most common agent is going to be propofol. Propofol's been around many years. Clearly, white medicine, seen in a syringe, very easy to identify. Known popularly as Michael Jackson juice, although I wouldn't use that reference when you're discussing it with patients or their families. Propofol, very effective. As an ongoing means of maintenance of anaesthesia, it is excellent. It can be titrated, it can be drawn up neat, it's very nurse friendly, it's very doctor friendly to use. What are the drawbacks of propofol? Propofol is hugely vasodilating. So you'll quite often see your patients who require sedation, then they start to require a background vasopressor to make up for the dilation that they've got from the sedation. That is not at all uncommon, and frequently on the intensive care unit would have a patient on a low dose of noradrenaline who would just be there because they're on a background of sedation. But propofol, very effective. When you turn it off, it wears off over the next 2 to 3 hours, your patient gradually lightens up and you can use it there. Good for procedural sedation, good for maintenance sedation. For the older people in the audience, not many, but for me certainly, we were often brought up with midazolam. Popular, benzodiazepine, classically made up to 50 milligrams in 50 mils of a syringe and then titrated, in common with an analgesic. We'll discuss the analgesic in a second, but midazolam, very effective. We don't tend to use it anymore these days because it is renally excreted, and a lot of patients on intensive care who've got renal impairment, what we're seeing with those patients is it takes a long while for midazolam to clear from the system. So for that reason, it's less popular. But midazolam, very cheap, very cheerful, does exactly what it says on the tin to do, but just takes longer to clear from the patient's system. Became very popular during COVID because its availability made it a good agent for these patients. And given that we weren't anticipating waking them up in a hurry, then certainly it seemed a very suitable agent. You may see it used, although not very often, ketamine. Now, during your time with us, you should get very experienced with ketamine. You should get to understand it. Ketamine, from the critical care point of view, is a wonderful drug. Clearly, it has both an analgesic and an amnesic effect, all in one package. For critical care induction, i.e. RSI in the sick patient, it is the agent of choice. It used to be frowned upon in head injuries because it was thought to raise the intracranial pressure, but that's really been disproven. Probably wouldn't use it for cardiogenic shock patients because it does give you a bit of tachycardia and therefore will increase your oxygen demands of your heart at the time. But other than that, it's an excellent critical care drug. As a background infusion, we don't tend to use it for many of our patients, but classically, the very tight asthmatic, ketamine is the agent of choice. Ketamine is a powerful bronchodilator, so in those asthmatics that come to the unit who are difficult to settle, and remember, within asthma, the intubation is usually easy. It's actually settling on the ventilator that's very, very difficult. The bronchodilation from ketamine is really handy. Those really are the only three agents you will see. You won't see etomidate used as an infusion anymore. That was very clearly associated with adrenal suppression, and so that has gone. You might see an opiate on its own. So some patients will happily just be very tube tolerant and settled purely with opiate analgesia going in. We're going to move on to opiates now. All of these agents, certainly propofol and midazolam, if you're using those with a patient, they all have an adjunctive opiate with them for the simple reason that it lowers the amount of sedation you need. And remember, none of these two here give any form of analgesia, so they will need some analgesia. So with sedation goes analgesia. We'll start with the fentanyls. There are many fentanyls: remifentanil, alfentanil, sufentanil, fentanyl. What do you need to know for the unit? The most common one of use is fentanyl. Prescribe. Welcome back. There's a brief interruption there for an ITU referral, so my apologies. We were discussing adjunctive analgesia, and we discussed a whole range of fentanyls, whereas the most common one we tend to use on intensive care is fentanyl itself. So the nurse will draw up fentanyl neat into a 50ml syringe, and it will sit there as a background infusion alongside your propofol, giving your patient adjunctive analgesia, lowering down the patient's requirements for fentanyl, giving them some degree of analgesia in the background, as well as some degree of just increased tube tolerance and general comfort and anxiolysis. So the adjunctive opiate is a very, very important element of what we give. You may well see remifentanil used. Remifentanil is a very useful drug. It has an extremely short half-life, and it is very nice for neurosedation. So let's imagine a scenario where you admit a patient to the intensive care unit. They've had a bit of a subarachnoid bleed, you've tubed and ventilated them, but what you want to do really tomorrow, nice and early, is to wake that patient up and therefore see what they're like neurologically underneath their sedation. With those, you might well sedate them purely with remifentanil. Or if you were to use propofol and remifentanil, you'd have to switch the propofol off early and then leave the remifentanil going in the background. Pretty much within a few minutes of switching off remifentanil, it will have cleared largely from the system, allowing you to assess the patient's neurology. So its ideal circumstance is as a single agent when you want to be able to switch it off and rapidly assess the patient. If that patient is requiring a long-acting sedative, then there is no point in having an ultra short-acting analgesic component with them as well. Remifentanil is very expensive, and whilst cost itself does not drive all of what we do on intensive care, we have to use our resources sensibly, and so with a long-acting sedative, you might as well use a longer-acting analgesic. Finally, in adults it's only relatively rare, but you may see it more in the peds, is morphine. Morphine we tend to use in conjunction with midazolam. Again, morphine takes a fair time to be excreted from the patient. It may well build up because of renal impairment in our critical care patient. So when you switch off your morphine infusion, it does hang around in the circulation and the system for some time. So we classically use morphine in conjunction with midazolam when we know we have no real need to wake the patient up in any form of a hurry. Classically, ARDS. We know they're going to be with us for some time. They've got horrible lungs, being ventilated, long-term sedation and analgesia use. Morphine midazolam would be a very good choice. Interestingly enough, in the paediatric group, so if you're called down to the resus room or to the F1 where you are involved in stabilising a child for retrieval, often intubated children can be sedated and maintained very happily just with a morphine infusion. They don't need ongoing midazolam or propofol. So that is very handy from there. So we've covered sedation, we've covered analgesia. What's left? Paralysis. Why do we paralyse a patient on intensive care? Well, the why, again, relates to the ventilator. We have a patient who is showing significant dyssynchrony with the ventilator. The hypoxic patient with ARDS, who we cannot get to settle on the ventilator, we may want to paralyse so we can take complete control of that patient. The asthmatic with stiff lungs who we can't get to settle on the vent, again, they're another classic one we may well want to paralyse. Some procedures where we don't want the patient having any movement, we've got sedation on board, so quite clearly we always want adequate sedation. We never want to have a patient paralysed with inadequate sedation, but doing some procedures we may well want to paralyse the patient as well to facilitate that procedure. The best drug, and pretty much the only drug you will tend to see on intensive care for ongoing paralysis, is atracurium. Why? So atracurium is broken down by plasma hydrolysis. It is therefore independent of liver and independent of renal function. So in our multi-organ failure patients, who you see on the intensive care unit, where these organs are impaired and therefore their drug excretion is going to be poor, atracurium is ideal because it's independent of those organ systems. Atracurium can be given either by boluses, and we tend to give a 50 milligram bolus, and that should last between 20 minutes and half an hour, or in those patients who you want ongoing paralysis, we will tend to have an atracurium infusion, and that's usually at the rate of about 50 milligrams per hour. You can always check the effect from that with your nerve stimulator, and the other thing you can actually also make sure is your patient is adequately sedated under the background of that as well. So look for tearing, signs of sympathetic distress, high blood pressure, tachycardias. The other drug you may well see or use is uranium. Now these days we tend, in the critical care patient, to use uranium as our agent of paralysis when we RSI them. Succinylcholine has become a lot less popular. There's nothing wrong with Sux, but its rapid wear off time just means it's probably not that ideal for these patients. Sux is great in the circumstance where you think, okay, I'm going to do RSI, but in fact, if I can't get the tube down, I want to come out, try something different at a later stage, and I want the paralysis to have worn off relatively quickly. The reason we're putting our intensive care patients off to sleep is not going to disappear. So therefore, coming back next week to RSI them is not an acceptable alternative. So using uranium, which has a duration of action of about 20 minutes, means that they do not start to cough at any stage in the RSI process. The key thing about uranium is you need to give enough of it, and you need to give enough of it, give it long enough to actually act before you then try and open the jaw. I know uranium comes in a 50 milligram ampule, and that's a reasonable thing for a maintenance dose, but a paralysis dose, like RSI for uranium, is 1 milligram per kilogram. In simple terms, in an adult, I never use less than 100 milligrams of uranium. And the times I've seen people struggle with inadequate paralysis is they've used a small dose of uranium. Remember, you cannot be over-paralysed, but you certainly can be under-paralysed. The other thing with rocuronium is, bear in mind, it takes a good 90 seconds to take effect. So when you give it to your patient, before then suddenly leaping in with a laryngoscope and wondering why the jaw doesn't move, just relax, wait for a minute 15, test the jaw. If the jaw's nice and relaxed, proceed. Get to 90 seconds if it's not, test again, okay, and then away you go. But give rocuronium long enough to actually act. There are other agents, vecuronium certainly. You might see vecuronium powdered, excreted by the liver, so very good in renal failure patients, but we don't tend to use vecuronium really, only at times of extreme shortage of the other agents. Pancuronium has pretty much disappeared from use. It was a very good agent. It lasted about 40 minutes to an hour, so you could give a dose and then it had plenty of time for it to act. But the thing with pancuronium was it made quite a few of the patients tachycardic, and there was a tachyphylaxis to it, so it tended to have lost favour. So these are the only real paralysing agents that you will see on the unit particularly. So really, in summary, we've discussed why we sedate people on intensive care and why we paralyse them. And that's really to achieve compliance with either treatment, particularly ventilation, or complete compliance with care full stop. We discussed the sedative agents, propofol, midazolam, ketamine, and some of the benefits of each of them. We discussed the fact that each sedative really is accompanied by then an adjunctive opiate to decrease the amount of sedative that you need, and we discussed the benefits of each of those. And then we've also looked briefly at the end at paralysis and why you might use a paralysing agent on the intensive care patient. Thank you very much for your attention. I hope that you found that useful. I look forward to seeing you on the intensive care unit.